Good morning, ladies and gentlemen and friends. And let me at the outset thank Santosh and also the All India Ophthalmological Society for this wonderful opportunity of giving a lecture in the Aishala, which I always cherish being here. And complications in cataract surgery, I'm going to take you through quickly some videos which probably will interest you, and some complications you might have faced in your practice, some complications will definitely face. Most of the complications you will face in this, whatever I am going to say in your, during your surgical practice or during a residency program as well. The most important thing is if you have a complication, and the difference between an ordinary and extraordinary surgeon is how he manages the complications. And you can manage these complications very, very well and give the patients very good vision, 6/6 vision post-operatively as well. So let's go through some basics. So this is the SICS. You can see here, I'm doing a tunnel which is a little superficial. Sometimes you can have a buttonhole, so I go a little deeper. This is a very, very common thing because you always go half thickness of the sclera when you want to start the tunnel. Sometimes you can use a guard knife for that matter. If you have a laser pointer, sir? Laser pointer? Yeah. So this is a very, very common thing because you need to make sure that the tunnel is very good in this SICS. Let me take one step above. This is a corneal burn, which is not uncommon, especially when you are using a very high phaco power in a hard brown cataract as well. The corneal burn is very, very significant because you don't want a tight wound and high phaco power. Sometimes you use the corneal power burn can have problem. Very difficult to suture this corneal burn, and if you can leave it, if you leave it like that, there can be wound gape, infection, even endophthalmitis as well. And sometimes it requires a multiple sutures. How to avoid a corneal burn? The one way to avoid is to prevent the excess phaco burn. Also make the wound a little, if you have it a little tight, what will happen is the heat will go from the sleeve across into the cornea as well, and they can end up in a corneal burn like this. And sometimes you don't remove the viscoelastic, especially when you're using high density viscoelastic like Viscoat, and then try to give the phaco power, you can end up in a corneal burn like this. This iris prolapse, I'm sure everybody would have gone through this iris prolapse, and it's a very, very common thing, especially in patients who are on the alpha blockers, that is the tamsulosin or the Urimax. And once you have an iris prolapse, always try to push in some viscoelastic like Viscoat, which will keep the iris back, and try not to manipulate the iris. If you try to manipulate the iris will start tearing, and you can have an hydrodialysis as well. If you look at this video, you can see here, look at this, one of my residents doing this. And once you do a hydrodissection, always do a depression of the nucleus. You can see what has happened, okay? There is a split because once you do a hydrodissection, what happens is the nucleus comes forward. You need to push the nucleus back, okay? You need to prevent that blowout. Sometimes the anterior capsule can split, and this can extend posteriorly as well, and it can have a posterior capsule blowout, and it can all of a sudden you can see the nucleus disappearing into the vitreous cavity as well. So always when you do a hydrodissection, the difference between a hydrodissection and hydrodelineation is hydrodissection is separating the capsule from the rest of the cataract. Hydrodelineation is separating the inner nucleus from the outer nucleus. So these are the two things you should do. Hydrodissection we do routinely. Hydrodelineation you do it in certain types of cataracts like traumatic cataracts, posterior polar cataract, and also previously vitrectomized eyes. Be careful not to do hydrodissection, do only hydrodelineation in such situations. How many of you ever had this problem? This is Argentina flag sign. Okay, this is a very, very not a very this thing, but uncommon thing, but it's quite common, especially when you have a type 1 intumescent cataract. As soon as it touches the cataract, you can see the rhexis goes to the periphery, and this is called the Argentina flag sign. Okay, the problem with this Argentina flag sign is, if you look at that the periphery, that one, the one which has gone to that side, that is the 6 o'clock. That is dangerous because that can go across the equator into the posterior capsule as well, and it can have a posterior capsule rupture and even a nucleus drop into the vitreous cavity as well. So once you have an Argentina flag sign, we'll tell you how to prevent this Argentina flag sign. But once you have an Argentina flag sign, the only way to do is you assess the density of the cataract always, okay? If it's a very brown cataract, I would advocate you to convert into an ECC or SICS, whatever you're comfortable. Otherwise, you can do a semicircular rhexis like this. You can see here, what I'm trying to do is, I'm doing a semicircular rhexis on one side, and then I have another semicircular rhexis on this side as well, and then making sure that I don't have any flaps during my phacoemulsification. This is a fairly soft cataract, grade 1 to 2. Though it's a white cataract, it's a very fairly soft cataract. So I thought I'll go ahead and do a phacoemulsification. I'm making sure that before I do the phacoemulsification, I'm converting that into 2 semicircular rhexis. So I have a fairly good rhexis there, and then I do what is called the direct chop technique, okay? I'm bringing the nucleus slightly up into the iris plane. I don't mind losing some corneal endothelial cells, but I don't want this tear, because only the chopping technique has got the least stress on the zonules as well as on the posterior capsule as well. So one thing is, always use good amount of viscoat into the anterior chamber, making sure that the corneal endothelium is well protected as well. And you can see here how I'm trying to do that and bringing that nucleus up into the anterior chamber, and this patient did very well. How to prevent an Argentine or flax sign? If you say, I think Partha is going to talk about it. If you have access to the femtocataract, this is the catalyst which I'm using for Argentine or flax sign to prevent an Argentine or flax sign, and then in intumescent cataract, almost 100% of the time you can get away with this. Or you can have access to Zepto. The Zepto works like this thing wherein it's a nitinol ring which works like an electrical impulse which is there, and you can see it. The Zepto, it's like a ring which opposes on the cornea. I'm sorry, on the anterior capsule. You can get a good, nice, beautiful rhexis which is much more stronger than the femtorhexis and the manual rhexis as well. Or you can do what is called an aspiration of the cortex. You can see here I'm using a 27 gauge needle there and aspirating the cortex in front, the front compartment, and by which what we can do is you can reduce the interlenticular pressure. The main problem in the Argentine flax sign is the interlenticular pressure. So you don't want the interlenticular pressure to come up and produce an Argentine flax sign. So once you aspirate that cortex, you can use even a 30 gauge needle. You can see here I'm trying to aspirate, making a very small opening, making sure that this rhexis does not go to the periphery, and decompressing the interlenticular pressure. Once you decompress the interlenticular pressure, then you can go ahead and do the rhexis as well. So the most important thing is the 4 components which are working here. One is the pressure underneath the anterior capsule. The nucleus is bulky. There's a pressure in front of the posterior capsule. There's also a positive vitreous pressure. All these white cataracts I always do under peribulbar block, and also give a super pinky. I give preoperative mannitol and Diamox to reduce the vitreous pressure as well. This is the 4th component as well. I have developed the technique called the punchorhexis. You can go in and put the blue rex or the trypan blue, and then go with the bevel down needle, the phaco needle, either 15 degree or a 0 degree, and you can see here I'm punching the anterior capsule. That is called the punchorhexis. Don't use very high molecular weight viscose. It's simple HPMC, by which you can just punch the anterior axis. It takes care of all the 4 components. So it takes care of the front component, the back component as well, and also by producing a small the burst of phaco, it debulks the nucleus and pushes the nucleus back as well, and preventing the nucleus. Because as soon as you touch an Argentine flax sign, what happens is the pressure which is there in the front of the posterior capsule pushes the nucleus up, and the rhexis goes to the periphery. If you don't have any access to the rotator forceps or anything, you can follow it by the phaco-rhexis. You can use the phaco needle itself. It involves a little bit of a learning curve, but you can punch as well as and do the phaco-rhexis as well with the phaco needle itself. It's a little bimanual technique as well, but it works wonderfully well. You can see here, this is another patient. You can see here. I'm quickly going on to the next video. You can see a subincisional cortex is one of the major issues. When you use a subincisional cortex, you can see here one of the residents trying to catch the subincisional cortex with a Simcoe through the side port, and what happens is there is a PC rupture. Okay. The problem is if you don't focus on the posterior capsule during the subincisional cortex, this is what will happen. You can see there's a PC rupture, and mainly because of the subincisional cortex. Always remove the subincisional cortex first when the bag is open, and then go ahead and do the other ones as well. If you have a PCR like this, you can see here, this is a PCR which has occurred, one of my phaco trainees. You can see here all of us get jittery, okay? This is a PCR which has occurred during the irrigation aspiration. The nucleus is also sinking into the vitreous cavity as well. And you can see here, once you have PCR, what happens is all of us become jittery. You might be operating on a VIP patient. You can see here, don't pull out. If you pull out, this is what will happen. The PCR is the vitreous is like a tsunami. Okay, the vitreous is more and more vitreous will start coming into the anterior chamber. So immediately I went into the this thing do what is called bimanual anterior vitrectomy. That is separate the irrigation from the aspiration when you have a PCR. That is the irrigation aspiration. The irrigation is on the left side, the aspiration. Then what happens to the nucleus? You pray to God, the nucleus will come up depending on the karma what you do. I can see here this is the nucleus. I supported that with the irrigation handpiece, and then I did the phaco, and then again bimanual. Once you have the PCR, don't use the main port at all. Use the two side ports. Remove the vitreous first, and then remove the cortex later as well. You can see this is another patient can PCR. Can anybody tell me what is the reason for the PCR in this patient? Any of the postgraduates? If any of you are doing phaco. So you can see this is the last piece I'm trying to take, and because of the post-occlusion surge, okay, when you have the last piece, always reduce the parameters. When you reduce the parameters means by reducing reduce the vacuum, reduce the flow rate, and this is what will happen. Okay, this is a small PCR there, but I didn't lose my calm. I always injected viscoat through this. The viscoat is something which is really tremendous, goes and plugs that PC tear as well, and then remove the phaco handpiece very slowly. Then don't use this main port at all. Always go to the side port, create two side ports, and many of us use bimanual. Always use the bimanual thing wherein the irrigation is aspirate and is separated from the aspiration. By coaxial, the irrigation and aspiration are the same, but the bimanual, the irrigation is separated from the aspiration, the irrigation is separated from the cutter. So once I did that, I made sure the PCR was the same in the beginning. Okay, by having a separate anterior chamber maintainer or the irrigation separated, what happens is that prevents the tear from extending and also prevents hydration of vitreous. And now what you require is to just remove the vitreous from the anterior chamber. You can see this is another patient. You can see here PCR has occurred during the last when I remove the zinc. Can you see the PCR there? Always inject viscoelastic. Don't pull out of the eye. Pull out of the eye, the PCR will extend. Inject viscoelastic. You can see a linear tear there on the PC. And then I always use bimanual IA. When I use a bimanual IA, I always make sure that when I come out of the eye, I inject viscoat or any form of viscoelastic for the matter, and come out of the eye. And then this patient, I couldn't convert that into a small piece in the capsular excess because the PC tear were extending almost into the equator. Went ahead and put a single piece lens in the bag, and the patient did very well. Okay, sometimes you can have a problem of a nucleus drop as well. Okay, this nucleus drop can occur during SICS, ECCE, or more commonly during the phaco as well. Can see that when my assistant puts viscoelastic on the cornea and the nucleus disappears into the vitreous cavity. Once you have a nucleus drop, you can see another patient with the posterior polar cataract. You have to be very, very careful in doing the hydrodissection. You can see here the nucleus disappears. So what you should not do is, once you have a nucleus drop, can anybody tell me what you should not do if you have a nucleus going into the vitreous cavity? Don't chase it. Absolutely, don't chase it. If you chase it, then you will end up in a giant retinal tear. Okay, and all these medical legal problems can occur. So only if you are an anterior segment surgeon, clean up the anterior segment, and then we can go ahead, clean up the anterior segment, remove the cortex, remove the epinucleus, remove the vitreous which is there in the anterior chamber, and go ahead and put a lens as well. But in this case, I just went in, and with this a posterior polar cataract, usually the nucleus is very soft. You can see here, went in and did I used the sleeveless phaco probe itself like a fragmentome, and then bring it up. And this can be done only by the vitreoretinal surgeon. If you are not trained in vitreoretinal surgery, don't try to do, because this is the 3-port sclerotomy you do. Nowadays you can do sutureless, 23 gauge, 25 gauge you can use for that matter. The 23 gauge fragmentomes are also available, by which you can see. You can see I bring the nucleus up, and then went ahead and removed the nucleus in the anterior chamber as well, and then because the rexus is intact, I was able to put a lens in the sulcus. Okay, if the PC tear, you can see here, this is the nucleus which I chopped, and then it's there. Okay, it is not gone down into the vitreous cavity. Then you can do what is called, which is there just in the pupillary area or in the anterior vitreous space, you can do what is called anterior assisted levitation or AL. You can see that you bring the nucleus up and then deliver it like just like the way you do it in a SICS, okay. Then obviously you have ruptured the anterior hyaloid phase as well, put an anterior chamber maintainer, always use tricot, okay, preservative tricot is free, tricot is available, all the Indian companies are making it now, making sure that you put the thing, and then I went ahead in this patient, the old patient, I went ahead and they put an anterior chamber angle supported lens. Only thing is anterior chamber sizing of the lens is very important, making sure that the pupil is round, there is no vitreous in the anterior chamber. Always don't forget to do a peripheral iridectomy in this patient, okay. Another patient, one of my residents doing ECC, she did a fairly good rexis, and then she wanted to deliver this nucleus. The mistake in this thing is, wherever there is pressure should be given, she has given counter pressure. Wherever the counter pressure should be given, she has given pressure. That's the reason why the nucleus started sinking into the vitreous cavity, because the upper pole of the nucleus has to come out when you give the pressure and counter pressure properly. If you don't do it properly, then you can end up in a problem like this. And you can see here the nucleus started sinking into the vitreous cavity, but it's not gone fully inside, it is still there. Then I went ahead and did what is called the PAL. What is called PAL is the posterior assisted levitation. I put a sclerotomy here in the upper temporal quadrant. This is the right eye, upper temporal quadrant. You can see here, put a sclerotomy, 3.5 millimeter from the limbus, and then introduce a rod and bring the nucleus up into the thing. Only thing is you need to make sure that this patient is not a young patient or a high myope, because you're going to the vitreous base. All these patients you need to follow very, very closely post-operatively, dilate them, look at the, do an indirect ophthalmoscopy of the periphery, making sure that you don't have any develop any retinal breaks or retinal detachment as well. You can see here how I'm trying to bring that up through the pars plana approach. That is called the posterior assisted levitation. Then you deliver it, and the patient, after that we did a glued IOL for this patient. The second sitting, and the patient did very well. Posterior polar cataract is another major issue. This posterior polar cataract, either you can do SICS, but phaco also you can do. Only thing is you need to be follow certain protocols with posterior polar cataract. Do not do hydrodissection, okay? Do only hydrodelineation in these patients. Don't do hydrodissection, and always do what is called slow motion phaco technique. If you're using 400 millimeters vacuum, make it about 200, 250. If you're using flow rate of about 45, 50, make it about 25, 30. Making sure, because you don't want things to happen very fast in posterior polar cataract. And please understand the aspiration flow rate is directly proportional to the followability of the nucleus as well. And you can see here this patient, as I am trying to remove the nucleus, the whole thing is going, the PC tear has occurred. It's not a PC tear actually in posterior polar cataract. It's a pre-existing tear which is there, dehiscence of the posterior capsule, which is usually 2 pillars, so you can see that. And then I do a bimanual anterior vitrectomy. Always remove don't use Mirocell sponges, don't use this cotton buds, or don't use dewaker scissors for removing the vitreous. And always use only automated vitrectomy. These are all the phaco machines are now equipped with all the posterior vitrectomy cutters as well. You can see here I'm removing the vitreous first, and then doing, every time I come out of the eye, inject viscoelastic, and then go ahead and do the lens. We can see the typical, the posterior polar cataract, the typical 2 pillars which are there, and this is the thing wherein I put a multi-piece lens, the MA60 lens into the haptic, and don't leave the haptic in the sulcus, and don't leave it in the sulcus like that. Always do what is called the optic capture, which I thought, okay, this is the optic capture. You can see is once you leave the lens in the sulcus, there's a possibility of the long-term decentration of the lens. You don't want that to happen. Also produce what is called UGH syndrome. And you can see here, this is the optic capture. You can see the haptic is in the sulcus. Then capture that optic into the capsular rhexis margin. Okay, once you capture the optic and seeing, you look for the ovalization of the anterior capsule. That is the end point for you to understand this ball game. So it's very, very important because this produces long-term centration, stability of the lens as well. And one of the thing, this is the post-operative pictures of this patient wherein this thing is another posterior polar cataract, young patient, young girl. You can see I do a femto for these patients. In the femto, you have the advantage. The catalyst, you have the advantage because you can keep the offset from the posterior capsule. You can see I do only hydrodelineation in the seeing a very soft cataracts, and by fairly young patient. You can see here, and I'm trying to just aspirate the whole the lens matter, which is quite very soft. Then inject viscoelastic every time I come out of the eye, and then go ahead and do the coaxial irrigation aspiration, and making sure the thing. Once I do that, then there is a plaque. There is a huge plaque on the posterior capsule. It's very difficult to yak these plaques, so I decided what to do what is called the plaque ectomy, wherein I remove that plaque. You can see here, this is a very little tricky situation as well, because it's very difficult to remove this plaque, and sometimes because I always use a bimanual technique, and then went ahead and put a symphony lens in this patient, and the patient did very well as well. So these are the posterior polar cataract, the take-home messages, and these are the hard brown cataracts. I'm going to show you some quickly pictures because running short of time, wherein the hard brown cataracts you can always use the trypan blue. When you use a trypan blue, because you know exactly where your capsular rexus margin is, so you can go ahead and do the trypan blue, and then try to not to be very, very aggressive in your hydrodissection. And you can see here, these are brown cataracts, very thick cataracts, like a piece of granite inside the eye. And use the chopper, which is a sharp chopper, which is devised by me. And you can see here, this is a vertical chopping technique, wherein I chop right in front of the capsular rexus margin as well. And you can use femtocataract, and yeah. This is another very common problem. Many of the patients are on IFIS, that is the having IFIS problem on Urimax as well, and you can see the iris is starting to come out, and this is a very, very major issue. Once you have an IFIS, it's very, very difficult to, if we try to push the iris back, you can produce iris can tear, or you can even have an iris dance like this, or you can see something like this, something like this when the iris becomes very floppy as well. And again, when the pupil starts coming down, the worst problem is in phacoemulsification or any cataract surgery is the small pupil. If you have small pupil, you're not able to see well, and you will have all the complications. And once you have an IFIS like this, always I do what is called, immediately I put iris hooks and go ahead with the patient. So this is again a patient with a subluxated cataract. You can see here the subluxated cataract, and I'm going ahead and putting iris hooks for the capsular rexus margin. There are capsular rexus hooks, the capsular hooks for the capsular rexus. Don't try to use, but just to show you that we can use iris hooks also for the capsular. Only thing is, don't keep the traction for too long. You can always produce what is called, give a circumferential traction by giving a CTR as well. Again, just to show you the zonular dialysis. You can see here, as I'm trying to aspirate the cortex, you can see here, look at this 6 o'clock meridian there. You can see that zonules are coming. Okay, the zonules are come. Once you identify the zonules are coming out, the zonular dialysis occurring intraoperatively, inject viscoelastic and come out. Always put a CTR there, and then stabilize, and then go ahead with the phacoemulsification as well. Just to show you a Morgaginian cataract, wherein these are the hooks. These are the capsular hooks. The capsular hooks rest on the equator and doesn't produce any rexus, any this thing on the rexus margin. Whereas the iris hooks rest on the iris this thing and can produce problem of tear on the rexus margin as well. Just to show you the microspherophakia, and I'll just take 30 more seconds, Chitra, just to show you that, and I'll skip this video just to show this traumatic cataract. And see this zonular loss as well, and then I'm going ahead with the femtorexis. Patient had traumatic mydriasis. Can see the iridodialysis also in the infranasal quadrant of this patient. So I went ahead and did this thing, a CTR, and then what is called single pass 4th row pupilloplasty. Is very simple technique which has been devised by Amar. So I will not go through that all these other things. I think it's very exhaustive as well. And once again, and thank this opportunity for giving. Thank Santosh and the AIOC for this wonderful opportunity to be here. So complications can be made easy, and you can have a good life, not only for the good sleep as well, not only for the patient, but also for the surgeon as well. Just for a final appeal for all of you, if you're not voted, 14th is the day, the Valentine's Day. Show your love and affection to me as Chairman Scientific Committee. Thank you.